Welcome to today's World Thrombosis Day expert discussion on optimizing outcomes in VTE, how intermittent pneumatic compression therapy makes a difference. We are pleased to have you joined for an interactive and engaging discussion on mechanical prophylaxis in venous thromboembolism, or VTE, including current trends, considerations for patient compliance, and how the healthcare community can work together to improve IPC therapy to treat blood clots. We would like to thank Cardinal Health for its support of this video. I am your host and moderator, Dr. Erich de Paula from University of Campinas in Brazil, where I serve as Vice Dean and Associate Professor of Hematology. I would like to share this disclosure slide. Please review this disclosure. Thank you. Okay. Now I am pleased to introduce our two fantastic speakers for today's interactive discussion. Please welcome Dr. Javad Parvizi, and we are also joined by Dr. Lana Castellucci. Thank you both for being here today. We are excited to get started with today's Q&A discussion, but before we begin, we would like to hear a word from each of our speakers about their background and expertise as it relates to today's discussion. Well, as I mentioned, my name is Erich de Paula, and I work at the University of Campinas, where I serve as an associate professor of hematology. In this position, I am involved in the discussion of thromboprophylaxis protocols with different specialties in the hospital, and this is a position where I have the opportunity to discuss issues such as IPC therapy. Now I would like to give the word to Dr. Parvizi to talk a little bit about his background. Dr. Parvizi?
Yeah, thank you very much, Eric, and thank you for the honor of being invited to be on this webinar together. My name is Javad Parvizi. I'm a professor of orthopedic surgery at Acıbadem University in Istanbul. I'm a practicing orthopedic surgeon with interest in hip and knee replacement, and I do that surgery now mostly in Europe. I was previously a professor of orthopedic surgery at Thomas Jefferson University and also held the position of vice chair of clinical research at Thomas Jefferson. I have a strong interest in venous thromboembolism. I have written some papers related to this subject. I served as a member of the guideline committee from the American Academy of Orthopedic Surgeons on prevention of VTE, the initial guidelines that came out. And I have been a reviewing expert for numerous other guidelines, including chest guidelines and others. And we also held an international global consensus on venous thromboembolism, which was conducted during the COVID era, the results of which have been published in Journal of Bone Joint Surgery and was picked by New England Journal of Medicine as one of the most influential consensus statements or guidelines that have been out there. So it is an area of huge interest to me. And again, it's a pleasure to be on this webinar with you. Thank you.
Thank you. Now, Dr. Lana, would you please introduce yourself to us?
Thank you. Thank you, Eric. My name is Lana Castellucci, and I'm an associate professor at the University of Ottawa in Canada. I'm a scientist at the Ottawa Hospital Research Institute, and I have the pleasure of co-chairing the World Thrombosis Day Steering Committee with Eric. Dr. Parvizi, thank you for being here with us. We really look forward to having your expertise as a surgeon to talk about this really important topic. I myself am a general internist by training with thrombosis expertise, and much of what I do is the medical management of patients with either VTE diagnosed or for primary prophylaxis. And so it'll be a great discussion today to see the surgical perspective as well as our medical perspective, as Eric and I both share that expertise in terms of a medical perspective on VTE management. Thank you again.
Well, thank you very much. And we would like this to be a very interactive discussion, but I will start proposing some questions. And Dr. Castellucci, could you please talk a little bit about the very basic concepts related to venous thromboembolism, What is VTE? What are the primary risk factors for getting a blood clot?
Thank you, Eric. So I think the important thing to know about venous thromboembolism is that it's comprised of both deep vein thrombosis, typically of the legs, as well as pulmonary embolism, which involves the lungs. And when we talk about DVT and PE or pulmonary embolism, we're talking about blood clots, and that's the most common terminology that the layperson will understand. And the blood clots typically start in the leg, and if untreated, a piece of that clot can break off, traveling through the body, and then end up as a pulmonary embolism or PE. And there are several risk factors that are important for people to know in terms of when is a DVT or PE at higher risk. And importantly for today's session, that a lot of that has to do with hospital-associated VTE. And so patients that are admitted to hospital may not be moving around, have medical illness, or even are post-operative from, in particular, certain surgeries such as orthopedic surgeries are at high risk for VTE. And then there are other situations that also carry increased risk. And importantly for us, for World Thrombosis Day this year, we're also focusing on women's health. And there are different stages in women's health where the risk for VTE is increased, such as with use of hormonal therapies, oral contraceptive pills, as well as pregnancy in the postpartum state.
Well, thank you very much. And now I would like to ask Dr. Parvizi to talk a little bit about IPC. If you could please provide us with a definition, what is actually IPC, what are the types, and then if you can talk a little bit about the role of IPC in the prevention of VTE.
Sure. Thank you, Dr. de Paula. Yeah, IPC, otherwise intermittent pneumatic compression devices, are mechanical devices that are applied to a limb, most of the time to the lower extremity, to apply compression to squeeze those deep venous deep veins in the leg and prevent deep venous thrombosis that Dr. Castellucci was alluding to earlier. So even though we put everything under the same terminology, IPC, they are not all the same. Not all of them are created equal. The best time to apply it is in the operating room when the patient is on the operating table, because that is the time, start of the surgery is usually when a patient becomes hypercoagulable. And there have been studies showing that some of these deep vein thromboses or even pulmonary embolus may arise during surgery when the patient is hypercoagulable. So having a device that minimizes that risk during surgery is very valuable. Most surgeons who use IPC apply it during the operation, and then of course followed after the procedure while the patient is in the hospital. Now, one of the biggest issues, and I agree with Dr. Castellucci, any procedure, but particularly orthopedics, puts the patient at a high risk of venous thromboembolism. But one of the challenges we are now facing, at least in the field of joint replacement, hip and knee replacement, is that our patients are going home on the same day. So I know we will cover this in a few minutes, but that has created a little bit of an issue in terms of the number of hours that an IPC can be applied to a patient in a hospital setting before they're discharged, the patient compliance, etc. So these are some of the challenges we face currently.
Okay, and Dr. Parvizi, going in the same direction, can you elaborate a little bit about the evidence of the comparative evidence that there's been around? I know that you've been involved in several guidelines discussion on the effectiveness of IPC in this setting, and also if you could comment on, aside from orthopedic surgery, what would be other high-risk types of procedures in which this type of device can be useful?
Yeah, sure. There is plenty of evidence to show that IPCs are very effective in minimizing the risk of venous thromboembolism, both venous embolus as well as pulmonary embolus. And there is even some evidence to show that the application of IPC to upper extremity is also effective. So not only IPCs not only they have a mechanical action, which we know about, they may also be very important in initiating a fibrinolytic type of a process in the body, and hence minimizing the risk of venous thromboembolism. The most common application of IPCs are in lower extremity surgery, knee replacement, hip replacement. But the risk of VTE is there for all other surgical procedures, not just orthopedics, but all other surgical procedures. And I think there are some that actually have very, very high risk of venous thromboembolism. For example, studies showing that some of patients undergoing a neurological surgery, be it spinal or craniotomy, they have in the region of 20 to 30% chance of developing distal DVT. So any patient undergoing major operation should be considered as being at risk of developing venous thromboembolism, and in my opinion, are candidates to be considered for IPC. Now, numerous meta-analyses are published, including a lot on randomized prospective studies. We published one on it also, showing that IPC in some circumstances is just as effective as chemical prophylaxis, including injectable medications and or oral medication. But the randomized prospective studies that have been conducted have been mostly by the use of one particular device. So our colleagues and listeners who want to really look at the evidence, they need to be very critical when they're looking at the literature to make sure that they take note of which particular device was used in those randomized prospective studies, and not take the liberty of extrapolating those findings to all comers. So again, as I mentioned earlier, not all IPCs are created equal.
Okay, that's very important. I would like to get back to that in a minute. First, I would like to hear from Dr. Castellucci on the importance of mechanical prophylaxis in patients who are unable to tolerate pharmacological prophylaxis due to bleeding risks. Is this also something that is worth discussing?
Thank you, Dr. de Paula. I think that's a really important component whenever one is faced with a patient, determining what their risk of VTE is and balancing that risk with bleeding risk. And in my hospital where I work, we have VTE risk assessment built into our admission orders. So it's a component of all patient orders entry upon admission to hospital that one needs to consider whether or not they should receive pharmacologic prophylaxis with an anticoagulant. And if they're considered to be high bleeding risk, then other strategies may be used, including IPC devices. One of the challenges that we face in our hospital is that not all areas of the hospital can utilize IPC devices effectively. So they are largely available in the intensive care units and in the operating rooms, as Dr. Parvizi mentioned, but we don't necessarily have as ready access to them on the wards. And so that's something that can be a bit of a barrier to their use beyond a surgical population. Certain surgical units will have them as well, because those patients may be considered higher risk for VTE, and the importance of reducing that risk is obvious. But having access to those devices for medical patients admitted to hospital, for example, can be a bit more challenging.
Yes, and I would like to, following up on that, to ask Dr. Parvizi about this issue, the compliance issue. According to a systematic review that I had a chance to read a few days ago, there are several aspects. One of each is the availability of these devices in different areas of the hospital. From your experience, what are the main barriers to compliance, and what can healthcare professionals do to overcome them?
Yeah, I think Dr. Castellucci very nicely mentioned some of them. Definitely expense is one. Some hospitals don't wish to buy these devices and make it available. And there are cheaper imitations of the effective devices in the market at the moment. In orthopedics, our biggest challenge is the fact that patients are not lying in the bed anymore. There has been a huge push towards fast rehabilitation. So as soon as the patient has the procedure, we have the physical therapist meet them, get them out of bed, walk them around the corridors, etc. So doing so has taken time away from application of IPC. It's still pretty challenging to have IPC applied and then have the patient be ambulatory. So that's becoming less. It is difficult, and maybe in the future that will change. The other is lack of knowledge, the lack of understanding that that IPCs are so effective, and both for physicians and also our allied health personnel. I think we need to invest some time and energy to make people understand that the IPCs play a critical role in prevention of VTE. And again, as I mentioned earlier, in my opinion, are just as effective as chemical prophylaxis.
Okay, and from that perspective, you mentioned a few times that there are different IPC devices, and that there can be one should be careful about selecting the ones that have been proved effective. Okay, and now I'd like to move to a different subject. At the World Thrombosis Day campaign, we have been investing a lot of energy in women's health issues. And of course, VTE is something that is part of women's health in different times of their lives. So I would like to ask Dr. Castellucci to talk us a little bit about how do hormonal changes such as pregnancy, hormonal replacement therapy increase women's risks of VTE, and what role can mechanical prophylaxis play in the prevention?
Thank you, Dr. de Paula. I think that's a really important question, not only because we are focusing on that topic for World Thrombosis Day, but because we face these patients on a day-to-day basis. And what we know is that changes in hormonal levels within our bodies and related to exogenous forms of hormones, whether it's oral contraceptive pills or hormone replacement therapies, those carry an increased risk of VTE. And it's important that people using those medications know that. In particular, it's related to the estrogen components of these medications, and those medications carry an increased risk of thrombosis. That's important for people who may be taking those medications and are admitted to hospital and may not be eligible for medication anticoagulants. So pharmacoprophylaxis, for example, and this may be an opportunity where using IPCs would be recommended in place of that. There's also times, as you mentioned, in the pregnancy state or in the postpartum state where a person may be admitted to hospital and again may be considered high bleeding risk, and so anticoagulant prophylaxis is avoided, and these devices could be used in those settings to try to reduce the risk of VTE. Importantly, for women who are post-cesarean section, that in and of itself carries an increased risk for DVT and pulmonary embolism. And so that may be a setting where, in particular, one wants to use IPCs if you cannot use an anticoagulant prophylaxis mechanism.
Okay, thank you. Dr. Parvizi, have you had any experience in helping people to implement these type of protocols related to women's health issues? Or do you have any additional collaboration on that?
Sure. I think that's beautifully summarized by Dr. Castellucci. But in orthopedic surgery, we do see patients who are either on hormone replacement therapy as a result of their underlying neoplastic conditions, or they are on hormonal replacement therapy, or even on the contraceptive medications. There have been studies showing that these medications, and as Dr. Castellucci said, particularly those rich in estrogen, increases the risk of VTE in these patients. So when we have patients undergoing elective orthopedic procedures, protocols are in place to try to see if we can minimize the burden of these medications and reduce their risk for our patients. So for example, at my previous institution, we had a protocol in place that patients on oral contraceptive medications were recommended to refrain from the use of these medications for a period of 4 to 8 weeks prior to their surgery, and also refrain from using them for another 4 to 6 weeks following the procedure. So numerous protocols are in place, and I realize they're not all exactly the same, but I don't think anybody today would doubt the fact that some of our women patients are at slightly higher risk of VT as a result of being on some of these estrogen-rich medications, and we should make every effort to try to minimize their adverse effect related to VTE.
Okay. Now I would like to ask you, Dr. Parvizi, based on your expertise on using these type of devices, in very practical terms, what do you think that healthcare professionals can do to make sure that the use of IPC is correctly documented and adhered to, and how to monitor their use in a daily routine in a hospital? What kind of suggestions would you give to a team that intends to start implementing this type of treatment in their area?
Great question, Dr. de Paula. So I personally think the IPC should be applied in the operating room for 3 reasons. Number one is that we then know where IPCs are going to go to. As Dr. Castellucci mentioned earlier, sometimes people are running around to find the IPC, or they don't know where to order it from. Does pharmacy? Does it come from? So having it in the operating room will certainly help address that issue of access. Number two, as we mentioned, surgery, at the initiation of surgery and the physiological insult of operation itself is a risk factor for VTE, and actually applying the IPCs in the operating room for the 1.5, 2, and sometimes 5 or 6 hours that a patient is on the operating table is in itself very, very important. 3 is you have to remember these patients go into post-operative recovery area, PACU, and they're there for quite a few hours. And if you're housing the IPCs up on the floor, patient could literally not see the IPC for 8, 10, sometimes 12 hours. And these are like critical. This is a very critical period during surgery that I think IPC should be applied. And then you can focus your energy in terms of education on PACU nurses and the importance of applying these, keeping them on properly. Some of these patients are still under regional anesthesia, and during this time it's a perfect time to apply them and allow this to sort of take effect. So, we have, of course, over the last 15, 20 years of using IPCs, tried to work out some of the kinks in the system. And I can't tell you that we worked everything out and we're perfect, but we certainly have moved in the right direction in terms of both improving compliance, but most importantly, the time, the application time, the number of hours that the patient has the IPC on improves if you start the process in the operating room.
Thank you. You mentioned time, and earlier you also mentioned the minimum time that IPC should be used. I know that this is a difficult question, but for a lot of us who are in the treating medical patients, this is also something that we always wonder. So is there an answer for this question? What would be the minimum time that IPC should be applied during or after surgery?
I'm going to let Dr. Castellucci answer that question first, because she's so much smarter and obviously read the literature better than I have. and then I can write on her answer. What about that? What do you think? Yeah.
Thank you. So from my limited experience and from what I know about this, I think my understanding is that 20+ hours a day is really needed for someone to wear them to achieve maximal benefit at reducing VTE risk. And I think that speaks to some of the challenges that you were talking about, Dr. Parvizi, in terms of compliance, both from a patient end and from a nursing care perspective as well. But I'm happy to hear your minimum duration.
Yeah, no, I agree with you. I think the longer it's applied, the more effective it is, for sure. And in terms of like the cost efficiency and cost effectiveness, clearly the longer you apply them, the better it is in terms of justification of cost. But any period of time when these are applied, it is still very, very useful, and it's better for the patients to have them on. But we have had issues with patients tolerating them up to 20 hours. Some patients can't sleep with them at night. Again, there are like other nuisance issues, what I would call nuisance issues related to IPCs that minimize their compliance. But that has been addressed for the most part by the newer designs that we have. So we also insist on having the patients wear them as many hours as they can, but we haven't been able to identify a clear threshold, both in the studies and the studies that we've done here. But I agree, the longer they wear, the better it is.
Okay, thank you very much.
Question. Just in regards to skin care when wearing the devices, and are there any concerns that people need to have with skin care breakdown, in particular, the way that we saw with graduated compression stockings, for example? Is there anything of concern that people need to be aware of?
Yeah, absolutely. Thank you for that question, Dr. Castellucci. There are some newer IPC devices that have been introduced specifically from one country that unfortunately I think has a lot of hyperallergenic material in the cuff and in the socks, and it causes quite a bit of reaction in some patients, redness, itching, and sometimes even superficial epidermolysis. So again, I think it's very important not to go after the most economic IPCs because cutting corners and like compromising on the quality of the applicators, the pump, all of these does result. Yeah, we do see that. We do see that. And then, of course, in patients who have an incision under the cuff, we have to be careful that doesn't also result in some wound-related problems. And some surgeons are very hesitant to apply the IPC to the area of the incision. I don't personally have a problem with the device that I use, but that's another thing to take into account. And then the application needs to be done properly by a healthcare professional initially, and patients' families need to be shown how to apply this. Applying it too tight, too loose, in the wrong anatomical region, over a flexion area like the knee, etc., can cause some problems. So that's why I think the education becomes extremely critical.
Okay, thank you very much. I think that this has been a great discussion. I think that the main points were related to the importance of, I have nicely addressed the importance of IPC, the potential, the fact that knowledge about this type of device needs to be, there's room for improvement in our hospitals, and also the main settings in which IPC can be important and effective. We also discussed some of the barriers to compliance, but we also learned that there's been a lot of work and there are ways to solve them. And finally, the fact that some aspects of different IPCs need to be taken into account so that we are actually using the most effective ones for our patients. So Having said that, I would like to invite our speakers to give a takeaway or closing remark if you want to. I would like to first invite Dr. Castellucci. Would you like to make any final comments?
Thank you, Dr. de Paula. This has been a really great discussion with you and Dr. Parvizi. Thank you again for having me. I think what I learned from this is that not all devices are created equal. And it's important to know that if you're going to use a device, that you understand it well and educate your team on application of it and continued use of it in patients that are considered high risk for VTE and have contraindications to pharmacologic prophylaxis. Thank you.
Thank you, Dr. Castellucci. And Dr. Parvizi, it's been great to have your expertise here. I think that for a lot of people, this is a field in which there is a lot of lack of knowledge, and a lot of people have a lot to learn about it. And thank you very much. What would you like to give us as a takeaway in closing remark?
Sure. Thank you, Dr. de Paula. It's been a pleasure to be with you and Dr. Castellucci. I've learned a great deal, as I always do, from my internal medicine, hematology, and cardiology colleagues. One, venous thromboembolism is real. We have to make an effort to try to prevent it. It is important for us to determine what is the most effective strategy for a given patient and try to individualize the VTE prevention or VTE prophylaxis to the need of that particular individual. 3, IPCs, intermittent pneumatic compression devices, are extremely effective in reducing the risk of venous thromboembolism, both distal DVT as well as pulmonary embolus. And their use should certainly strongly be considered for a lot of patients undergoing surgical procedure at least. And as Dr. Castellucci alluded, they're not all created equal. Please read the literature to see which of them have evidence behind them and try to use them. Education is very, very critical in terms of both improving compliance and also improving on the efficacy of these devices, both to the patient and healthcare providers. And finally, there are some unintended yet extremely important benefits of IPC for us as surgeons, which we didn't even discuss, and that is reduction of swelling in the lower extremity, improving the range of motion, patient satisfaction, earlier ambulation, return to function. All of these are like very, very nicely highlighted in the literature related to orthopedics. And most importantly, as you alluded to earlier, Dr. de Paula, some of our patients are at very high risk of bleeding. And bleeding in these patients is critical. It is bleeding into critical cavities like brain, like the abdominal cavity, or even the joint where we operate on. And remember, IPCs bring the risk of hematoma formation and bleeding down too. So those are very, very important for us to bear in mind when we are choosing the most appropriate VTE prophylaxis.
Well, thank you very much, Dr. Parvizi and Dr. Castellucci, for sharing your insights and expertise today. It has been a very interesting discussion. Thank you again to Cardinal Health for its support of today's video. And to learn more about World Thrombosis Day, which takes place on October 13th, visit www.worldthrombosisday.org.